Thank you, Ben. So my area of expertise is medical oncology, and this is where we focus on drug-based therapies. These are the whole body or systemic therapies. This is a great complement to the surgery and the radiotherapy where we focus on sort of localized treatment. That was discussed by Jonathan and Michael just before. We're looking to treat, I guess, the whole of the brain, what's left behind. Just by way of further background, I guess in general our management approach depends on the type of tumor we're treating, and that's often based on the cell origin of the cancer and also by the grading. And just to simplify things, this is just a schematic of some of the key cells within the brain. We obviously have the nerve cells, those neurons, but supporting these neurons are what we call glial cells, the support cells. And one of the key ones are these so-called astrocytes. They interface between the neurons and the surrounding blood vessels and environment, and very important for providing nutrition to those neurons. Tumors which arise from these astrocytes are called astrocytomas. And another key cell within the brain are these oligodendrocytes, and they have a different function. These blue cells, they wrap around those nerve fibers and provide insulation. And this is very important to allow those nerve signals to conduct down those nerves efficiently. And tumors that arise from the oligodendrocytes, we call them oligodendrogliomas. And then Jonathan alluded to this before, this idea of grade or aggressiveness. Grade 1 tumors are much less aggressive. Grade 4 tumors are aggressive and actively dividing. And the concept here is that grade 1 tumor, these cells look much more similar to normal brain cells, and grade 4 tumors are much more bizarre and very different. And grade 4 tumors are much more likely to grow quickly. And so we combine these concepts between the cell of origin and the grade, and we come up with the specific sort of diagnostic terms. This is a simplification, but you have at the top the grade 1s going down to grade 4. Grade 4 tumors are the glioblastomas, which unfortunately are the most common form in adults. And then in terms of naming, the astrocytomas, if they arise from the astrocytes, versus the oligodendrogliomas, if they arose from the oligodendrocytes instead. I guess over the past 4 or 5 years, we have supplemented this with increased knowledge about the molecular characteristics of these tumors. For example, we know with the polycytic astrocytomas, a large proportion of these will have a particular aberration in the BRAF gene. And this is interesting because we have specific drugs that can target this if this is present. With the oligodendrogliomas, instead of just looking under the microscope to see whether it seems to be coming from one of these cells, there's a specific aberration called a 1p19q co-deletion, which tells the pathologist that this is an oligodendroglioma. And then, although glioblastomas, typically we diagnose them based on this grade 4 appearance under the microscope, we now know that even if a tumor looks a little bit less aggressive, say grade 2 or 3, if they harbor some of these adverse molecular features that you can see at the bottom, for example, if they have a normal IDH gene, but they have these sort of chromosomal or TERT EGFR aberrations, that they may behave more aggressively and more similar to a standard glioblastoma. And the significance of this is that we may be inclined to treat them more like a glioblastoma rather than a low-grade glioma, despite the appearance under the microscope. And so with this schematic, this is kind of how we decide how intensively we'll treat these tumors. The lower grade tumors are more likely to be, more localized, so surgery and radiotherapy are more the mainstay. And then as you move towards the more aggressive glioblastoma, which tends to be very diffuse in nature, we need to sort of throw in the whole package and do surgery, combined radiotherapy and chemotherapy, followed by further chemotherapy. So this gives some guide as to why we have this sort of multimodal approach. Again, this concept of diffuse that Jonathan alluded to right at the beginning, this is an electron microscope appearance of glioma cells in green. You can see that there is a central core of cancer cells, but they are spread out and quite diffuse. And the concept here is that you might take out the main tumor bulk with surgery. You might supplement that then with some radiotherapy to that surgical cavity region. But you're still going to have these cancer cells away from the primary site. It's really hard to mop up every single cell. And this is kind of where the drug-based therapies come in. We're trying to treat more diffusely through the brain with these drugs. In terms of the drugs that we have, the mainstay, really since at least 2005, has been this drug called temozolomide. This is what we call a survival curve from that pivotal paper back in 2005 by Stoop and colleagues, where patients underwent surgery followed by either radiotherapy alone or radiotherapy with the addition of temozolomide. And survival curve, basically the vertical axis shows the proportion of people who are still alive at a particular time point. And we can see in the blue that with the combination, that survival curve is lifted upwards, which is a favorable thing. And just to give a guide, you can see that this is back in 2005, in terms of the time point for 50% of people to still be alive with the radiation alone was about sort of 12 months, and then when you added the temozolomide, maybe 14 to 15 months. But I guess what was even more interesting to us is that you can see that sort of long tail where in blue, it actually stretches it out more towards 5 years. There is a small group, maybe sort of 2 to 5%, who will still be doing well at that point. And so although we have this aggressive, incurable, very nasty glioblastoma, there is a very small subset that with maximal therapy, there is some hope that they could do well, albeit that is the minority still at this point. Some of you may be familiar with this idea of MGMT promoter methylation, that now with glioblastomas, we tend to subdivide them into those which have this methylation and those which are unmethylated. And the significance here is that if you do have this favorable methylation, irrespective of the treatment you get, you tend to do slightly better than those who have an unmethylated MGMT promoter. And also within those groups, the separation between those two curves, that perhaps adding the temozolomide is slightly more advantageous in that group where you are methylated, that might be a particularly responsive group. And in terms of what this is, methylation basically means to turn off or silence. So if you have methylation of the MGMT promoter, the tumor cell is making less MGMT. And MGMT is a DNA repair enzyme, and so if it's turned off and it's not present, the tumor can't repair DNA damage as effectively. And so when you give temozolomide, the tumor gets damaged, it's not able to repair as quickly. So we think these tumors are more likely to respond well to treatment such as temozolomide. So this is generally a favorable thing to have. And I guess the core drug temozolomide, why did we pick this? This is a drug that's a very small molecule. It can be taken as a capsule because it can be absorbed through the gut, but also can be absorbed effectively through those tight junctions in the brain and get into the tumor. And inside the tumor, it then gets into the DNA and forms cross-links, which prevents these cells from effectively dividing. We still give temozolomide with this standard regimen where you have the radiotherapy typically between 3 to 6 weeks, and we give daily temozolomide alongside that. You have a 4-week break, and then we have further monthly cycles of temozolomide where for 5 days, every 28 days, you get some further chemo. And the principle here with the monthly chemotherapy is that you cause some damage, both to the tumor and slightly to the normal cells, and then during that gap, the normal cells should have a chance to repair themselves. The cancer cells have that defective repair. Hopefully they can't repair to the same degree. And you sort of repeat that. And at the moment, typically most of us will treat for sort of up to 6 months, and we will then reassess how you're going at that point. I guess in terms of other drugs, I mean, once temozolomide is no longer effective, if there are no sort of other good local regional options, such as further surgery or re-irradiation, what other drugs do we have? Probably the 2 other drugs that are fairly commonly used at the moment would be lomustine, bevacizumab, or the combination of the 2. This is just, again, from another paper showing survival curves, comparing the combination of lomustine and bevacizumab versus lomustine alone. Potentially with the combination, the time to further tumor growth might be delayed, but the overall sort of survival outcomes still look to be fairly similar in this particular study. And so I think your doctor may, for different reasons, prescribe one drug or the other or the combination. Bevacizumab is quite a different type of drug. It's not a standard chemotherapy. Bevacizumab works by actually targeting a growth factor for blood vessels called VEGF, vascular endothelial growth factor. And the concept here is that instead of directly attacking the tumor, you're trying to stop the growth of abnormal blood vessels that feed these tumors and deprive these tumors of the key nutrients they need to grow and divide rapidly. And bevacizumab might have particular advantage when you're worried about swelling. The other advantage is that it helps to shut down that leakiness of the blood vessels. And so perhaps we might be more inclined to try bevacizumab if we thought there was a component of swelling, if a patient needs a lot of steroids and you can't wean that down successfully. Bevacizumab might be particularly useful, whereas lomustine is much more similar to temozolomide, that more standard sort of cytotoxic killing chemotherapy. And so there might be advantages of one versus the other. Sometimes we might give the combination. And so that has been our key armamentarium. Still in 2021, in terms of drug-based therapies, we have temozolomide, lomustine, bevacizumab, potentially interlinked with further surgery or radiotherapy, depending on the situation. And that might seem a bit depressing. That's just our limited arsenal at the moment. But I guess where are we going to, and where's the hope going forwards? One of the key ideas here is the possibility of personalized therapy. And this is trying to find something unique about your particular glioblastoma, and we can find some unique mutation. Maybe we have a drug that can target that in a much more specific way compared to the whole body sort of chemotherapy. There are a few programs that have been helping us to do this. One of them is called the MOST program, been run through the Garvan Institute, but it's a national program where in tumors, including brain tumors, where you have sort of gone through the standard treatments, we don't have many options left. They will take these tumors and do genomic profiling for us, trying to identify something that might be unique about that tumor. We recently also ran a pilot study called Lumos, and this focused more on the lower grade 2 or 3, the diffuse or the anaplastic gliomas, where in people who need repeat surgery, we took that tissue and looked at the genetic makeup at that point and then tried to find unique targets that we could help guide further treatment at that time point. And I guess in terms of the targets that we may be looking for, we know that particularly with those lower grade 2 or 3 gliomas, a large proportion of them will have this IDH mutation. And there are a group of drugs that are being developed at the moment in various stages of trials trying to effectively block this IDH mutation, and so that might be a potential targeted therapy. Some of these tumors, a very small proportion, have this thing called an NTRK alteration, and we have some drugs that can actually target this quite effectively. At the moment, if we know that your tumor has this, the most have a sub-study that allows to access larotrectinib. And then there are a range of other potential growth pathways that we sometimes find, and I guess there's a whole group of drugs that have been developed trying to block these individual pathways. Now, sometimes it's not that straightforward. A tumor may have several pathways that are working simultaneously, so maybe blocking one pathway may not be sufficient to control the tumor growth. And the other condition here is that we need drugs that can effectively get into the brain, and so that does limit some of our options. So that's one sort of area of advance. Another key area that we're looking at would be these immune-based therapies, and the concept here is that instead of targeting these cancer cells directly, we try to harness the strength of the immune system. And basically we're trying to upregulate the immune system to recognize the cancer for us and then use the immune therapy arsenal to attack it directly, or sort of indirectly, having sort of primed the immune system in advance. An example of this is we had a trial called NUTMEG, a national trial looking at a drug called nivolumab, which is a PD-1 blocker. PD-1 is what we call an immune checkpoint. And the idea of blocking this immune checkpoint is that we sort of turn off one of the brakes on the immune system and make the immune system much more active. And hopefully, by turning off the brakes and getting the immune system to recognize the cancer, we can have this potential durable benefit where the immune system continues to be dynamic and continue to recognize the tumor. Now, admittedly, this has been very successful in some other tumor types, such as melanoma, and now sort of lung and bladder, head and neck, and a range of other tumors. We haven't had as much success to date with this more standard strategy. And so there are a range of other types of immune therapy that people are looking at. This is more in the preclinical or early clinical phases, so still some work to do, but these are interesting and exciting areas that we're looking at. There was a paper published about 2.5 years ago in one of our big journals looking at a form of modified poliovirus. Polio is a virus that can naturally get into the central nervous system quite effectively. And what they did is modified it so that instead of causing polio, it actually helped to attack these glioma tumor cells. The survival curve on the right is these are patients who had recurrent glioblastoma. And although the majority still did not have much benefit from this, you can see this interesting phenomenon where with those who had the modified poliovirus, there is a proportion who, sort of stretching out to 5 years from recurrence, still seemingly doing very well. Now, this is very small numbers, but it was exciting, and there's actually a whole range of modified viruses in development in various stages at this point. There's no limit to creativity. Vaccines are very topical at the moment. There have been attempts for a long time to create vaccines against targets that are unique to the glioma tumor cells. There's this group of treatments called dendritic cell therapy. Dendritic cells are cells that are important for surveilling the environment, trying to find infection or foreign cells in the body. And the idea here is that you take out the person's dendritic cells. In the lab, you then prime them against unique proteins in the tumor, and then you reinfuse these dendritic cells. Hopefully, these activated dendritic cells can then turn on the rest of the immune system. And then you also have this group of sort of modified T cells, whether that be sort of CAR T cells or BiTE cells. There's a range of T cell technologies. And again, the idea here is that you take out the person's T cells, and then outside in the lab, you modify them in some way to directly attack the cancer and reinfuse them. The T cells are sort of the key effector cells of the adaptive immune response. And so if you can modify them in a particular way, maybe that will then leverage that immune attack response. Another area that has been of great interest is this concept of the blood-brain barrier, that one of the limitations in terms of why we only have a few treatments available at the moment is that many drugs that we think might be useful in the lab can't get into the brain very effectively. One of the potential concepts is to use this thing called focused ultrasonography. Basically, you inject some microbubbles, and then over the region of the tumor, you'll shoot some ultrasound waves, and these bubbles will expand, and they'll cause temporary disruption of the blood-brain barrier. And the idea is to try to give the drug during this period of temporary disruption, so you can get maximum sort of diffusion into the tumor, and then that disruption will naturally heal. There's also these group of treatments called nanoparticles. So if a drug can't naturally get into the brain, perhaps another strategy is to package it within sort of a carrier protein, which can get into the brain. So this carrier protein will get the drug from the bloodstream into the tumor cell, where it will then be released, and then the drug can do what it needs to do. So this is sort of a transport vessel. There was some news recently about sort of silver line nanoparticles, and actually a whole range of these are in the works. And again, this is very interesting and exciting. There's sort of preclinical models demonstrating that this seems to be a viable strategy, but at least to my knowledge, we haven't really got into serious clinical trials at this point. So still some work to be done. And the final aspect is really the idea of efficiency of clinical trials. It's been a long time. Temozolomide was sort of set up in 2005, and now in 2021, haven't made too many advances since then. And the older strategy has been to really do one sort of big trial, one after another, go for phase 1, 2, 3, try one drug. If not successful, you try again, going through this sort of sequential strategy. I guess that's not very time efficient. And what we're trying to do now is be a bit smart and have these so-called sort of adaptive or platform trials where you can ask many research questions simultaneously using the same set of patients. And thus you can try to ask more questions and potentially assess more drugs more quickly. And hopefully we can therefore work out whether a drug is useful or not. If not, we move on to the next one and get through that cycle much more quickly. Magma is a trial that's going to be available. It's been set up across Australia for patients with newly diagnosed glioblastoma. At the moment, there are two particular research questions looking at the timing and duration of temozolomide. But the concept of the platform is that as new research questions come up, they can be added to the platform over time dynamically. As certain questions are answered, they will be removed from the protocol. So the idea of this is that this will be a rolling platform that keeps going, which provides a trial infrastructure for questions to be asked along the way. And so I guess, where's the hope going forward in terms of, drug-based therapies? I think these are, to me, the 4 areas of great interest. The idea of having personalized therapy, the idea of using the immune system, ways of expanding our options in terms of drugs by breaching that blood-brain barrier, and finally, by using modern trial methodology to more efficiently answer some of these questions. And hopefully with the combination of these, we might start making some additional advances. And I think we'll probably leave questions to a little bit later on.